Good afternoon, everyone. Hi. We're going to get started. So welcome everyone. Welcome everyone here on site at the Health Sciences Center and those who are attending by webcast. So just want to welcome everyone to our education session, Medical Assistance in Dying, Ethical, Legal, and Practice Considerations. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I will be co-moderating the panel this afternoon along with my colleague Pam King-Jesso, nursing consultant with the Association of Registered Nurses at Newfoundland and Labrador. This year marks the 14th anniversary of our collaboration to host this annual event, and what a wonderful partnership it has been over the past 14 years. So today's session is being offered on site from the Health Sciences Center main auditorium and by live webcast. While this event is organized by the NLASW and ARNL, we would like to acknowledge the Munn School of Nursing for supporting this event and the College of Licensed Practical Nurses, Newfoundland and Labrador for their financial support in helping us bring this session to health professionals across Newfoundland and Labrador. We would also like to thank the Center for Innovation in Teaching and Learning for being here today to allow us to have a webcast for this session. Please note that this session is being video recorded and will be made available on our websites following the event in about 2 to 3 weeks. So we do have a tight time schedule for today's session. We're going to begin with a presentation from each of our panelists, and this will be an opportunity for them to share information pertaining to medical assistance in dying from the different perspectives. Many of you may have already attended a session on this topic, while for others this will be new information. Regardless, we hope that you'll leave the session today with new insights to enhance your knowledge and understanding of this important topic. Following the presentations, the panelists will have an opportunity to reflect on a case scenario and some frequently asked questions that healthcare professionals have raised. If time permits, we will invite members to ask clarifying questions, and these questions are meant to be limited to the information presented by the panelists and the material that's presented this afternoon. So we do ask you to keep your questions succinct and with the understanding that this session is being recorded. And for those of you who are attending by webinar, the email address for you to email your questions is educationwebcast2017@gmail.com, and that email address will run across the screen as well. And we will have microphones in the room for those of you who are attending on site to ask questions. With the passing of legislation in June 2016 to allow for the lawful provision of medical assistance in dying, it is timely that we're exploring this topic today. This session will explore what medical assistance in dying is, elements of the legislation that healthcare professionals need to be familiar with, an introduction to some of the ethical and professional considerations and resources that exist to assist healthcare professionals with respect to MAID. It is anticipated that the session today will spark continued discussion and reflection on this important topic. The focus and content of today's session is not meant as legal or organizational advice. You must consider the material within your own context of practice and seek guidance where appropriate. So without further ado, I will now introduce our wonderful panel of knowledgeable and experienced professionals who've generously volunteered their time to plan and lead the discussion this afternoon. So I'll start with Trudy, my closest to my left. Trudy graduated from Memorial University of Newfoundland with a Bachelor of Social Work in 1983 and worked for a number of years as a social worker before embarking on a legal career. She graduated from Dalhousie University with a Bachelor of Laws in 1993. Trudy is an experienced litigator appearing before both the Trial Division and Court of Appeal of the Supreme Court of Newfoundland and Labrador. Trudy was legal counsel for the Association of Registered Nurses, Newfoundland and Labrador for 17 years while in private practice until joining ARNL staff in January of 2015. She was formerly a partner with the law firm McGinnis Cooper. Trudy is a member of the disciplinary panel of the Law Society of Newfoundland and Labrador. She has been a sessional lecturer at the Faculty of Business Administration at Memorial University for over 20 years. She served 6 years as director with the Victorian Order of Nurses and was a member of the Health Research Ethics Board at Mons Medical School for 11 years. So welcome, Trudy. Next to Trudy, we have Michael Harvey. Michael is the Assistant Deputy Minister, Policy Planning and Performance Monitoring with the Department of Health and Community Services, a position that he's held since August of 2015. He previously served as Executive Director, Planning and Coordination in Cabinet Secretariat from 2012. He joined the provincial government in 2006 with Intergovernmental Affairs, where he worked for 5 years in progressively senior positions. He has also worked for the Department of Child, Youth and Family Services as Director responsible for policy and strategic planning. Prior to joining government, Mr. Harvey was a university instructor in political science, including as a lecturer at the University of Guelph and an instructor at the University of Toronto. Mr. Harvey holds a Master's of Arts, Political Science from Queen's University and a Bachelor of Arts Honors from Memorial University. Next to Michael, we have Judy Davison. And Judy is the Regional Director for Rehabilitation and Palliative Care for Eastern Health. As a speech-language pathologist, Judy became interested in the ethics of healthcare decision-making as she gave considerations to recommendations for enteral feeding of dysphagia clients, and particularly the cessation of feeding. This led to a greater involvement with Eastern Health Ethics Service, committee participation and involvement in the creation of Eastern Health's advanced care planning policy. Also, as a graduate student in British Columbia in the late 80s, Judy was part of healthcare teams working with many ALS patients with bulbar symptoms. Following that exposure and with her own clinical caseload, which included patients with ALS, Judy followed the Sue Rodriguez case of the early 90s with interest. Now, as a leader of palliative care services, Judy recognizes MAID as a new part of end-of-life care, separate from palliative care, but intrinsically connected to it. And last, but certainly not least, next to Judy, we have Daryl Pullman. Daryl is Professor of Medical Ethics, Director of Health Research Unit, and Bioethics Program Director in the Faculty of Medicine at Memorial University. He also has a clinical ethics appointment with Eastern Health and the Provincial Health Ethic Network for Newfoundland and Labrador. Daryl has broad and diverse research interests, including genetics and ethics, end-of-life care, and ethics and aging. He has served on many national ethics boards and committees and is currently a member of the Ethics Committee for the Royal College of Physicians and Surgeons of Canada. So what a wonderful panel. My goodness, so much expertise and knowledge. So without further ado, we're going to start the panel presentation, and I will invite Trudy to the podium to speak first.
Thank you, Annette. Good afternoon, everyone, and welcome to our session this afternoon. I'm going to speak to you sort of mostly about the legal implications of medical assistance in dying. And I'm going to give you a broad overview. I'm going to talk a little bit about the criminal code. I'm going to talk about the history of MAID, because I think it's important to have an understanding of how we got to where we are today. I'm going to talk about the amendments to the criminal code. I don't intend to get into the minutiae of those amendments because time simply does not permit it, and apparently I have 10.5 minutes. So I think I've just used up 3. And then I'm going to talk about some of the key considerations that you as healthcare professionals need to be aware of as we embark upon this new era of medical assistance in dying. So to start, let's start by looking at where we were prior to June 17th of 2016. Because in June of prior to this period of time, the criminal code had very specific provisions that dealt with assisting someone with death. And section 14 of the criminal code, and I'm not going to read it out, but basically you couldn't consent to have someone assist you with dying. And the big provision for healthcare professionals was Section 241 of the Criminal Code, because that particular section specifically prevents, or prevented at that time, someone from aiding or abetting someone in suicide. So that was the pre-June 17, 2016 provisions. So we've moved from that. So I'm going to talk a little bit about the history of how we got to be where we are today. And I think we can not embark upon this discussion without talking about the Sue Rodriguez case, which was one of the first cases out of our Supreme Court of Canada that dealt with this issue. And in that particular time, back in 1993, the Supreme Court of Canada, which is the highest court of the land for us, the court there, when having to address this particular issue and whether or not Ms. Rodriguez was entitled to facilitate her own death and be assisted in dying as she chose, the court had difficulty in supporting that decision. And the reason it had difficulty was with those provisions of the code, Criminal Code Section 14 and Section 241 of the Criminal Code. But there was some dissent amongst the court. And you'll see here that I've identified that the decision, Ms. Rodriguez lost by a very narrow 5-4 margin in the Supreme Court of Canada. And the challenge at that point in time was a charter challenge. And in 1993, the charter was still somewhat in its infancy in terms of how it gets applied, what it really means, what are we talking about when we talk about concepts such as someone's life, liberty, and security of the person, and someone's equality rights. So the courts were still grappling with what those terms meant back in 1993. And it was also guided in the Rodriguez case by some evidence, because in court, that is what makes decisions, the evidence that's put before the courts. And in this particular case, the Rodriguez case, a couple of things that the court noted. In 1993, no Western country had expressly permitted assistance in dying. From an evidentiary base, the court noted that there was a moral and ethical distinction between passive and active euthanasia. The court was also concerned that there was no halfway measure to protect the vulnerable, and that was a big concern for the Supreme Court of Canada at that time. There was also substantial consensus in Western countries that a blanket prohibition was necessary because they were concerned about the slippery slope. So that was the factual basis for the Rodriguez decision. But I think it's fair to say, given the court's struggle back in 1993 with this issue, where you have 5 judges out of 9 judges saying no, and 4 judges saying yes, then it I think, set the groundwork for the proper type of case to come before the courts. So this is where we come with the Carter decision. So Carter was a decision that was ripe for change. In Carter, and as I've said, there was certainly the impetus, I think, for the changes to the criminal code. And I'll just give you a little bit of factual, I don't intend to belabor the facts here, but I think it's important to have some understanding as to what the court was faced with in the Carter decision. And the impetus for Carter was a lady by the name of Gloria Taylor. And back in 2008, Ms. Taylor had been diagnosed with ALS. And she had made a determination that she wanted to decide how to end her own life. And this, I'll just repeat some of her own words. She did not want, and I quote, to live in a bedridden state, stripped of dignity and independence, end quote. She did not want her life to end violently and wanted, quote, the legal right to die peacefully at the time of her own choosing in the embrace of her family and friends, end quote. So that was the impetus for the courts looking at what we do in this circumstance now that we're faced with this again. So she actually brought a decision to the Supreme Court in British Columbia, which is the first level of court. And the court in British Columbia, the trial division judge in that case looked at the facts. And the facts had changed, and the facts in this particular case had changed significantly. And some of the information, the evidence that the court looked at, that the trial division looked at, was a number of things. For one thing, from 1993 to 2010, things had changed. In 2010, 8 jurisdictions permitted some form of assisted dying. So that was a change from 1993. As well, Quebec had also passed their own legislation ending life care. There were other pieces of information the court looked at as well, and one piece in particular, and this was again led through evidence, through expert witnesses and so forth that was presented, that general compliance with regulations in jurisdictions that permitted assistance in dying had safeguards that were working that protected the vulnerable population, which was a big concern in the Rodriguez case. There was also societal consensus that withholding or withdrawal of life-saving or life-sustaining medical treatment is ethically acceptable. And the court also noted that no ethical distinction between physician-assisted death and other end-of-life practices whose outcome is likely to result in death. So those were the changes that led to the trial division's decision in BC that the time was right. The other piece to all of this is that the charter, while in its infancy in 1993, had evolved significantly by the time it got to court in this particular case in 2010. So there were better directions provided by the court as to how we interpret Section 7 of the Charter and how we interpret Section 15 of the Charter. And it was as a result of that that the court in Carter decided that it was time to change. So the trial judge in Carter agreed with the sections of the criminal code were contrary to the charter. And before I go there, I will say to you that while the trial division judge made a finding that there was a breach, that the criminal code contravened the charter rights of Ms. Taylor, the Court of Appeal didn't agree with that. So this matter went to the BC Court of Appeal. The Court of Appeal in BC disagreed, overturned that decision, and it then got appealed to the Supreme Court of Canada, which, as I said, is the highest law of the land. And this is what the Supreme Court of Canada determined, that Section 241B and Section 14 of the Criminal Code unjustifiably infringed Section 7 of the Charter and were of no force or effect to the extent that they prohibited physician-assisted death where a competent adult who clearly consents to the termination of life and has a grievous and irremediable medical condition, including an illness, disease, or disability that causes enduring suffering that is intolerable to the individual in the circumstances of his or her condition. So, as a result of all of that, the Supreme Court of Canada decided that they would give governments, because this is a big change, so the Supreme Court of Canada decided that they would give government a year to do whatever legislative amendments was necessary to facilitate this change. And the timelines for doing this were a little bit tighter than people had hoped that they would be. Ultimately, the Supreme Court of Canada extended the timeline for governments to put something in place to June of 2016. And on June 17th of 2016, we saw amendments passed to the criminal code that in fact made it legal to provide medical assistance in dying. The amendments to the criminal code actually create an exemption for medical assistance in dying, provided that it is carried out in accordance with the provisions of the criminal code. So there is a very prescriptive provisions in the criminal code that mandates exactly how this is to be facilitated. So what are the key considerations? One of the key considerations here is, first of all, to have an understanding of what we're talking about when we're talking about medical assistance in dying. You'll recall from the Carter decision, the court talked about physician-assisted death. The Government of Canada, in making amendments to the criminal code, expanded the impact of providing assistance in dying to call it medical assistance in dying, recognizing that not only would physicians be involved in having to carry out and provide assistance in dying, other professionals in the healthcare field would certainly be involved and needed protections as well. And there was a great deal of lobbying that went on by numerous groups, social workers and nurses and licensed practical nurses, that all made representations to protect individuals within the profession that could be at risk if proper provisions weren't provided. So actually, medical assistance in dying is actually defined in the criminal code. And it is defined to say the administering by a medical practitioner or nurse practitioner of a substance to a person at their request that causes their death, or the prescribing or providing by a medical practitioner or nurse practitioner of a substance to a person at their request so that they may self-administer the substance and in doing so cause their own death. So those are the two circumstances that give rise to medical assistance in dying. The caveat that I will say here, while the criminal code references nurse practitioners may provide medical assistance in dying, in Newfoundland right now, the scope of practice has not been extended to enable nurse practitioners to engage in providing. They can certainly still assist and aid in MAID, but they cannot actually provide MAID, and that is a piece of work that is still in progress with the Nursing Association. So the next question or distinction that I note there is the distinction in actually providing MAID and aiding in MAID, because I think it's important to recognize that there is in fact a distinction. So when we're talking about providing in MAID, that's someone who's actually doing the administering, someone who is actually has the ability to write a prescription, actually administer the substance directly. Aiding in MAID is a little bit different. You cannot, if you're aiding in MAID, actually administer the substance. You can provide care and perform your activities within your profession's scope of practice, but you cannot actually physically and directly administer the substance. I'm going to come back to this next bullet here, where I identify that it is an indictable offense under the criminal code where someone counsels or abets a person to die by suicide. And I'm going to talk about that in a little bit more detail when we get to one of the case scenarios. Because when we're talking about nurses, licensed practical nurses, social workers, we need to understand that there is a big distinction between what the criminal code defines as to what it means to counsel and what counsel means in a therapeutic type of relationship. So that's a significant piece that you as professionals out there working need to understand and appreciate that distinction. The one thing I do want you to recognize here, that there is a specific clarification in the criminal code for social workers, psychologists, psychiatrists, therapists, medical practitioner, nurse practitioner, or any other health professional where they provide information on MAID, provided that that information is done in accordance with the criminal code. And we'll talk a little bit more about that as well. And I know I'm probably out of time here, so I will move quickly. Things you need to know about the amendments to the criminal code from key considerations. The criminal code actually specifies the eligibility criteria for MAID. So it is actually set out as to who can qualify for MAID. A medical practitioner or nurse practitioner providing MAID must adhere to the safeguards and requirements set out in the criminal code. So there is another section that actually sets out the safeguards, what you need to do to ensure that you are adhering to the criminal code. Significant next bullet. A medical practitioner or nurse practitioner who knowingly fails to comply with all of the specified requirements under the code is guilty of an offense. So that's significant. So you need to have a good understanding as to what the eligibility criteria are, what the safeguards are, what the requirements are. Final point here is that nothing in the criminal code compels an individual to provide or assist in MAID. So that was significant for many individuals. And the reason being is that when we're talking about conscientious objection, just as the individual charter rights for life, liberty, and security of the person to choose the way in which they die if they meet the qualifications in MAID, similarly, someone who has moral objection to assisting or providing in MAID, their charter rights are equally valued by our court system. So that is why the courts, the federal government specifically put this in there, is to alleviate those concerns for individuals who wanted to be able to conscientiously object to providing or assisting in MAID. So I know I'm out of my time, so I'm going to pass it over to Michael.
Thanks, Trudy. Thanks, Annette. So first of all, I want to thank you to the organizers for asking me to serve on this panel. When I came to the Department of Health and Community Services about 1.5 years ago, one of my directors mentioned to me that there would be a couple of meetings the next day, one with a Newfoundland Labrador working group and the other with a federal, provincial, territorial teleconference on medical assistance in dying. But he said it's a federal issue primarily. You don't really need to be worried about it. I don't think it's going to be a big deal for you. He was very wrong about that. It's been a busy year, but the one matter that I've spent the most time on has been this one. Over the past 1.5 years, I've met with individuals and groups representing a broad spectrum of Newfoundlanders and Labradorians to talk about medical assistance in dying and what the province's response to it would be. Health professionals, faith-based groups representing people with disabilities, various diseases and disabilities, Aboriginal organizations, seniors, and so on. And I do want to thank Trudy because usually that talk would have started with a talk just like the one you gave, with a PowerPoint and the whole deal. So I'm very happy that I didn't have to do that today. So thank you for setting the context. And I don't have to speak quite so precisely as I have had in the past. Instead, what I'd like to talk to you about today are the principles that are informing our thinking on the policy recommendations that we're about to make to government on what medical assistance in dying will look like in this province. Because right now we're about to do that. I'll speak a bit more about that in a moment, but I will say that in this province, medical assistance in dying did not emerge on our agenda because of a groundswell of support for it at the local level, as we've seen in other jurisdictions around Canada, and in Quebec, in Ontario, in British Columbia, or for that matter, a court case in this province. There wasn't a real drive from the bottom for this to happen. Or for that matter, there wasn't a real drive from the top. You won't find medical assistance in dying in the Red Book or in a speech from the throne. This is something that came onto our agenda because of things that were happening elsewhere in the country. But that said, once we started to talk about it, I was really struck by the passion at which people felt about this issue. And it really tapped into a real current of thinking that's running across the country, but is strong in this province as well, about how we as a healthcare system and as a society think about death. And how we care for people that are dying, and how we think about people that are dying. So that has really, to a certain extent, and I mean, I'm the kind of guy who likes to look for the silver lining in every cloud. I like to see this as an opportunity that didn't come from here, but that was thrust upon us, but nevertheless gave us an opportunity to look at something that is a part of life for every single one of us. That said, I've also been struck as I've been traveling about the province and speaking to different people about the degree of consensus that I've seen. If you've been reading about medical assistance in dying in the media it tends to be characterized by disagreements among people on this topic. But and don't get me wrong, there's lots of people disagree on certain specific points. But I've been really struck by the degree of consensus that I've seen. Because there are a small number of people who believe in complete and unfettered access to medical assistance in dying, and then there is also a small number of people who do believe that it should be not allowed under any circumstance. But for the most part, almost everybody starts from a position of compassion and empathy for patients, families, and healthcare professionals. And then they move on from that starting point to inform a nuanced position on the subject. And I think that, my experience here has not been characterized by conflict, which has not been the case in every province in this country, but really by a desire to look for a consensus and a moderate way. And I think that says a lot about our culture. So back to the issue of our provincial policy decisions. You may be asking, why are you only moving forward with recommendations on policy about provincial programming now? The law has been in force since June. That's 7 months or so. What have you been doing? You also knew it was coming. Now, I should say that while we knew the law was coming, we didn't know what would be in it until royal assent. Even as it moved through the House, it was very unorthodox. As it moved through the House of Commons and the Senate, we didn't know until that ink was on the stamp what exactly the final bill would look like because of the specific dynamics of that legislative process. But that said, we have taken our time to develop provincial programming. And in that time, that has not to say that medical assistance in dying has not been happening, because indeed it has been happening in this province. There have been a number of cases in Eastern Region and in Central, and in each of those cases, the regional health authorities has been involved in providing support. So provincial resources have been used as part of our public health care system to provide medical assistance in dying to people that have requested it. So what we haven't, we have been providing that access. What we haven't done is we haven't made the policy decisions on what a coherent medical assistance in dying regime will look like across the province. And so that's what we are now preparing to do, and I want to talk to you about is our positions on that. So I want to talk about 5 principles that have informed our thinking. And it's not, generally speaking, you won't get government officials talking about what the specific recommendations are to cabinet. So I'll try to be a bit coy about that. But I've been having so many conversations with people about this that I'm quite comfortable in talking to you about the principles that underlie our thinking. The first principle, and I do think it is the first principle that I want to talk about, is patient centricity. This has been the starting point for almost everybody, that medical assistance in dying needs to be patient-centric. Now, sometimes you might hear that this means resident-centric, if we're talking about a resident of a long-term care facility, or sometimes the term is patient and family-centric, although there we do need to be careful that it's the patient's view, not the family's view. The decision for medical assistance in dying needs to be the patient's decision, made freely and without coercion, not pushed in that way by the family. But we also can't pretend in the real world that the family is not important. But nevertheless, the starting point needs to be patient centricity. So this, what does the patient want? What's right for the patient need in the view of the patient is a critical starting point. And to a certain extent, this goes right back to the Carter case, where there is, in the definition of a grievous and intolerable condition, there is a subjective component built into that definition. It is not to the healthcare provider to determine whether the suffering is intolerable. That is a subjective decision that is to the patient to make. So there is I see a direct link back to the Supreme Court decision, and the patient centricity flows not only from that, but it does flow from that. So this will flow into the second principle that informs our thinking, and that is, of course, where this came from, and that's rights. So, as Trudy talked about, medical assistance in dying is legal in Canada now because of a Supreme Court of Canada charter case. And so we do need to be aware of the rights of the patient. But in a society like Canada's, rights are never absolute. In a democracy, rights can never be absolute. And in this case in particular, the patient's rights need to be balanced against the health provider's rights. Your Section 7 rights need to be balanced against Section 2 rights. So we must remember that as we move forward with medical assistance in dying programming, we need to balance the rights of everybody that are involved. Another critical balancing point has to do with safety. The administration of medical assistance in dying must be safe for everybody involved, and this means that, and this can be a qualifier on the patient centricity, because there may be situations in which it is not. The patient may want medical assistance in dying administered in a certain way, in a certain place, but it may not always be safe for it to be administered in that context or in that way. So, the patient may want to die at home. So you certainly hear a lot from health practitioners. It's almost an assumption that most people, given the choice, would prefer to die at home rather than the hospital. I'm not sure that that's always the case, but nevertheless, that is certainly what we hear a lot. It may be possible and preferable for that to be the case, but it may not always be safe for everybody involved. We also need to be worried about the safety of the health professionals themselves. And here I'm primarily talking about the potential harm and suffering that they may take on by performing this act. I mean, our healthcare system needs to give consideration to the wraparound supports that is provided to the people that are part of this act. They should do this for everything that you do, but in this particular case, this is a new element of our healthcare system, and so we need to be particularly careful in this way. So for that reason, the thinking about safety, among other things, is part of what is leading us to conclude that we need to have, we need to ensure that all the right health professionals receive the proper training and are available to provide support on an as-needed basis. So there's been discussion of interdisciplinary teams, doctors and nurses and social workers and ethicists and pastoral care workers and others as needed, including the availability of people with expertise in determining consent, people with expertise in palliative care that are trained on the subject that can be drawn upon on an as-needed basis to provide support to patients and healthcare practitioners. So in large part, this is driven by the safety principle. I'll say one final point related to safety, and that has to do with reporting. Trudy mentioned that it is not that nurse practitioners or medical practitioners who administer MAID must comply with the Act. One of the requirements in the Act has to do with reporting. The federal government will regulate reporting directly to the federal government. They haven't done that yet, but they will have done so within about a year to a year and a half from now. And that reporting will be mandatory and sanctionable. So that is critical. We need to know what's happening with medical assistance in dying so that we can ensure safety of the patients. We can ensure that the decision to die in this way was truly that patient's decision, that consent was independently witnessed, and that the patient truly did have that eligible condition. The fourth principle that I refer to is equity, though not necessarily equality. I'm sure that many of you would have seen that little image of the kids trying to watch a baseball game over the fence, where standing on crates. If kids of different heights stand on the same crate, then some of them are going to see over the fence and some of them aren't. But if everybody gets the help that they need, they can all get what they want. In this province, providing a healthcare service, any healthcare service for that matter, to every person equally, will not lead to equity in outcome. It will not lead to the safe and appropriate provision of those healthcare services. So we do need to be judicious in how we administer our programming to make sure that everybody gets the service that they need. So we will aim to provide this service in an equitable manner, but medical assistance in dying in Nain isn't going to look like medical assistance in dying in Mount Pearl. That's just not the appropriate way to do it. The final principle, and I do think this is the final principle because this speaks to the future, where we see this going, is that in the long run, we would hope that medical assistance in dying will be normalized in the sense that it is considered to be a normal part of the full continuum of end-of-life care, but not normal. We would expect, and looking at other jurisdictions, that only a very small percentage of people choose to die in this way. And again, I reference the choice. That concept of choice, that could be another principle on its own, but I see that as part of patient centricity and rights for that matter. But the idea is that only a small number of people will choose to die in this way. Maybe 3% would be what we would expect. Really, what we need is for it to be one component of a broad continuum of end-of-life care, and we also need to be sure that people are not choosing medical assistance in dying because of access to high-quality care at the end of their lives. So normalized but not normal means that we didn't want to, and we don't want to, create a medical assistance in dying regime or service that is somehow separate and apart from the healthcare services that are the entire rest of the system. It needs to be integrated and it needs to be normalized, and thereby that's where we can look at look for the silver lining for this cloud and see the attention that that is drawn to end of life by medical assistance in dying, and recognize that if we're going to be heading down this road, we are heading down this road, then we need to give greater attention to palliative care. This is a priority, certainly a priority of the government and of this minister. So that's where we see as the future. So that said, I do want to thank you for giving me the opportunity to talk to you about this today. And with that, I'll wrap up.
Thank you, Trudy and Michael. That information was so helpful in terms of setting the legal and provincial context, so I do thank you for that. I'm going to turn things over now to Judy.
Thank you, Annette. Thanks as well for inviting me to be here. For my presentation today, I thought I'd sort of explain a little bit or tell a little bit of the story about why I'm here, or why, as a leader with Eastern Health, responsible for regional palliative care, I end up here. And it's a little bit of a segue, I guess, from what Michael just said. So certainly, Eastern Health's clinical palliative care staff based in St. John's anxiously followed the Carter case that we heard about. Team members participated in national forums and gave their voice to opinion discussions that helped build the Canadian legislation. And as a group of physicians and healthcare professionals, they were very quick last year to react to the federal bill C-14 when it was announced in February. While the provision of medical aid in dying is a new part of end-of-life care, it was felt by our palliative care team that MAID needed to be separate from palliative care services. Palliative care and hospice care providers nationally have generally adhered to the World Health Care Organization definition of palliative care, which encompasses the whole person for patients and families and treats all symptoms with excellence and with compassion without hastening or prolonging natural death. Palliative care professionals have worked very hard for years to build trust with patient families. Many practitioners are wary that introducing medical aid in dying will undermine this trust and will deter many patients and families from seeking quality palliative care that they need and that can be provided to them. Palliative care units and hospices have traditionally been safe places for patients and families, places where patients and families are not fearful about the treatment they're going to receive. But that being said, and more as what Michael said, the legalization of medical aid in dying has provided an opportunity to highlight the need for consistent, accessible, and quality palliative care for all Canadians. It's about giving Canadians every choice in an informed way. That's part of good end-of-life care. That's part of what we need to do. So as the Director of Palliative Care Services for Eastern Health, I joined our group of healthcare leaders navigating the new legislation, professional regulations from the different professional bodies, and deliberating on service provision. As has been said, 3 patients in Eastern Health in the Eastern region have received medical aid in dying since June and have had what we're going to call a good death. Other patients have made inquiries, and new cases are expected and are happening every day, or coming to our attention every day. Currently, I sit as part of a working group coordinating these MAID services until a more formal process or service exists, and we have a lot of work to do, but we're not alone. While I can't speak to the specifics of the other 3 health authorities in the province, I know MAID is on everyone's agenda. Some groups are farther ahead in planning and policy and development, but we are all open to share and support each other. Right now, compared to other provinces, our number of requests for MAIDs is low. Provinces and jurisdictions that were quick to have physician champions were able to build services around those doctors. In some cases, the large number of requests presented a more immediate need to build a service to support patients, families, and healthcare providers. In Eastern Health, we hope to learn from those jurisdictions. This is new for everyone in Canada, but there's no reason to recreate the wheel. From an administrative point of view, it's important that patients and families contemplating medical aid in dying be directed to resources that will help them understand the process and to help them make informed decisions. The resources we imagine will likely be web-based with links to legislation, definition documents, and frequently asked questions, so the public can know how to access the services they are looking for that may include MAID, might include palliative care, and certainly bereavement services. From a health authority point of view, Eastern Health plans to develop a policy on medical aid in dying. Inherent to the policy will be algorithms to guide healthcare professionals' decision-making and also the required actions at each step in the decision process. We will advise on medical record keeping and develop approved forms to help guide practitioners in matters such as patient assessment and the reporting, the required reporting, as Michael mentioned. Pharmacy order sets and protocols will be formalized, and a standardized debriefing process will exist as part of the ongoing evaluation of services, as well as to support participating healthcare professionals. Some of this material is currently in draft. We're continuing to build. We hope that by developing these processes and tools, we will positively impact the comfort and confidence of those professionals interested in working in the area of medical aid in dying. We feel that by having standardized guidelines and tools, we will assist willing healthcare professionals work within their professional scope of practice to support patients directly. Eastern Health recognizes the need for a consistent, compassionate, and patient-centered approach to responding to a patient's inquiry regarding medical aid in dying. And we anticipate over time that a growing number of patients will seek that information. We need to be prepared to answer questions, we need to help prepare our staff, and we need to be prepared to fulfill the requests. We're really pleased that work has begun.
Thank you so much, Judy. It's interesting to hear the work that's happening at an organizational level and the work that's going to continue as we look at this service province-wide. And now I'm going to hand things over to Daryl Pullman, and I'm going to put your slide up for you.
That'd be great.
Daryl.
Great. Thanks, Annette. So I've titled my slide here, Some Ethical Reflections, or probably better, Reflections of an Ethicist, because these are my reflections on some of the process that's going on around this very important subject, medical aid in dying. As we've already heard, it's a paradigm shift in healthcare. It's changed the way we think about end of life and what kind of healthcare services we'll be providing at the end of life. Because up until the time this new legislation came into place this past June, generally the idea was that we would not be actively assisting people to end their lives. That's changed now, and we will be, and now we have to think about how we're going to accommodate that. As I was sitting there just listening, I was reflecting on, I was involved in an ethics consult just very recently. And it was about how do we continue to manage this very complex patient, and it's clear that the patient's deteriorating and so forth. But again, a wonderful healthcare team, very concerned about how we manage this on a go-forward basis. And I asked the question at one point. I said, "Has palliative care been invited into the discussion yet?" And no, we haven't done that. And I said, "But we've got a terminal patient here." Right? Well, we don't think the family's quite ready to talk about palliative care. And the question was, well, when do we start talking about palliative care? If we are going to talk about medical aid and dying, we have to be talking about palliative care. And that's, and so in fact, we're going to have another ethics consult about this particular case where we're going to bring in the palliative care kind of option. And for people that work in palliative care, and I've talked to many of them, they say, boy, we talk a lot about medical aid and dying now. We've got all kinds of groups to manage every aspect of medical aid and dying, but we've been talking about doing palliative care for a long time, but we just don't ever seem to get to that point. And so, as I said, some of my reflections as an ethicist, and I'll be upfront from the get-go, I've thought about, wrote about, and talked about medical aid and dying for a lot of years, and I've had a very conservative position. I've generally been against that. And I used to finish off my talks when I gave these talks, and in fact have included this quotation in some of the things that I've written. It's by a physician ethicist from New Zealand. He wrote a number of years ago, he said, physician-assisted death must remain against the law. However, there may be exceptional circumstances, and that's my emphasis, in which it is the ethical thing to do. And those of us who work in healthcare, we know, in spite of all of our best medical interventions, there are going to be certain kinds of situations where we simply can't manage it, given everything that's available. We know that in some respects our interventions are actually prolonging suffering, and we've come to grips with the fact of withdrawing interventions and so forth, but we know there are exceptional cases when maybe it would be the ethical thing to do would be to somehow hasten this person's death. But those should be the exceptional cases. Those shouldn't be the rule. And as we continue our conversations around this, as you think about your professional role as a social worker, a nurse, or whatever else your professional involvement might be, we have to think about how do we maintain this as just an exceptional practice that happens in the exceptional cases and doesn't become the rule. Because one of the concerns we have is that it becomes our first option rather than our last option in terms of dealing with very complex cases. So that's where I wanted to start with that quotation and say, well, now it is the law. So how do we make sure that we maintain it as an exceptional case? Oregon, the state of Oregon in the United States is the first jurisdiction in North America to actually allow for medical aid in dying, or in this case, it's a physician-assisted suicide. And the term is appropriate here because in Oregon, physicians don't actually, inject or actually administer the drugs and so forth to terminate a patient's life. They simply provide a prescription to a patient who requests it, who meets their criterion and so forth. And they started doing that back in 1998. So they've got quite a history of doing this. Now, with the state of Oregon, its population is about 1/10 that of Canada, so put those numbers in perspective. You could just kind of multiply all the numbers by about 10 and say where was Oregon. So in their first year, they had 24 people that requested assistance in dying, and that actually received a prescription to end their own life, but they had 16 people that actually carried through on that. And as you can see over the years, and the last year we've got here is 2015, it's continued to increase over that period of time, so that in the most recent one, 2015, that we've got the numbers for here, there were 218, I don't have my glasses on here, so I can't see, 218 people that requested, and 132 people that actually carried through. Now, of course, again, that's a different kind of regime there because it's only physician-assisted suicide. People are actually still taking their own lives, but they were being assisted by a physician to ensure that they've got the right medication and the appropriate dose that will actually result in their death. In Canada, that's one option, but the other option is that a physician or a nurse practitioner could actually be directly involved in administering it and so forth. But the numbers there over that about 18-year period now is that they've had 132. Now, if you multiply that by 10, that would be 1,320 would be the equivalent in Canada. In Canada right now, and this is our first year, our first 7 months, the numbers are, and we're not quite sure, and that's one of the problems we have, there's probably been about 800 people in Canada that have died as a result of medical assistance in dying. So if you extrapolate over the rest of the year, we're probably going to have more deaths in Canada in our first year than Oregon has had after 15 years. Now, again, there's a lot of different factors, and it's probably not fair to compare them on a one-to-one basis because we provide it differently in Canada. We've had 18 years of people getting used to the idea, when in Oregon they were the first state that did this and so forth. But just to keep in mind where we're going and the nature of the context in which this is happening. Because in our first year, we're probably quite possibly could have close to 2,000 deaths in the country. And if we keep, and that's in our first year, if we keep moving forward, it could become much more routine than some of us might be comfortable with. And especially if we're not providing, if we can't even start the conversation around palliative care, then we've got to be very careful that that what we offer people is well, this is an option for you, is medical aid in dying. So from an ethical perspective, those are some of the concerns that I have as an ethicist, that as we move forward, and we are trying to be very deliberate, we're putting a lot of resources in trying to make sure that we get this right, or as right as we can in the circumstances. But there's a whole cultural shift that's taken place, and a whole lot of energy that's going into to making this, the media's picking up on it, and it's like you've got a right to this. And now we've got a responsibility as healthcare providers to ensure that your rights are being honored in this area. And so we're in a very critical time here in terms of how we think about end of life and how this particular shift is going to factor into that. Here's a couple of quotations that because I do ethics and because people know that I'm involved with this issue, these are just things that physicians who, in one case it was a physician in an elevator, she said, you know, I've been an oncologist for over 20 years, and you'd think that oncology would be one area where people would really be concerned about, you know, I don't want to live anymore, you know, my cancer is terminal. She said, I can't ever remember a patient raising the question of medical assistance in dying with me. Although I've talked to many palliative care physicians who say, yeah, we have people ask us about that all the time, but we ask them, well, what is it that's causing you to make this decision now? What can we do to change your to change your situation? Because of course, when it was against the law, you simply couldn't offer anything else to them. But now that we've got this option, is that going to change the nature of our conversation when people raise the issue with us? A physician just told me this last week in conversation. He says, many of us can probably think of cases over the years where we knew that what we were doing might hasten to death. That is, we knew that, you know, if we prescribe this drug at this dose, it's probably going to result in a shorter life for this person. But all things considered, they're at the end of life. We're simply hastening a death. He said, but that was a matter of hours, or maybe in some cases days. He says, but weeks or years, because the law, as Trudy pointed out, has given us criteria that are kind of open to interpretation, and we're trying to sort out some of those things. And what does reasonably foreseeable mean? I heard a physician in a talk not too long ago. He said, well, in the Carter case, she wasn't actually terminally ill. Mrs. Carter wasn't actually terminally ill, and given her age and the condition she was suffering from, spinal stenosis, she could have lived another 5, maybe 6 years. So maybe we should say reasonable foreseeable is 5 years. Now, that's a little disturbing if we start going down that. But the law is kind of the way it's the criteria are set out right now is leaving it kind of open-ended. So we have to think about how are we going to put some kind of parameters around this. And I had another quotation from a physician who I'm on, as I mentioned, I'm on the Royal College of Physicians and Surgeons of Canada Ethics Committee, and we had a discussion just earlier this week about medical aid in dying. And one of the physicians there, he said, the Supreme Court decision fundamentally changed the nature of the relationship between the physician and the patient. He said that it's changed that nature of that relationship, and now we have to think about how we're going to manage that. So those are some of the things that we're dealing with. So we've got a cultural shift. What we have to be concerned about is that we don't medicalize suicide. You know, suicide is not against the law in Canada. It was in the criminal code up until I think it was 1972. It was against the law for you even to commit attempt suicide, but that was taken out of the criminal code. So it's not all against the law to commit suicide, but generally when somebody is suicidal, our response is, what's wrong? How do we prevent them from ending their life? But when when we're talking about medically assisted suicide, it's somebody says, I want to end my life, and our first thing was, well, how do we go about helping you to do that? That shouldn't be our first conversation at that point. We should be exploring still, what is the quality of life we might be able to provide for you still? What can we do to assist you to enjoy what life you've got left? Our first option shouldn't be, well, you know, you've got that right, and therefore we're going to be providing this for you, especially when we have a hard time raising that discussion around palliative care. So some of the issues that are still open, and we expect we're going to get some kind of direction through the courts or through Parliament as they look back at the law and amend it, or what about mental illness? Should people who are mentally ill be able to say, you know, I've been suffering from depression for 20 years, I can't stand it anymore. From my perspective, my life's not worth living. Should we be allowing them to have assistance in their dying? I was involved in there was a cross-country colloquium that dealt with that just last week. How about mature minors? Should mature minors be able to request assistance in dying? How about people being able to put it in their advanced directives? Or people with dementia? Another disturbing thing, because we're still in the early days and we're still in a situation where people are kind of having to sometimes make things up, make the rules up as they go. And a physician in BC who has come up with her own 4 criteria that she uses about people who are in early stages of dementia as to whether or not they're competent to make the decision. Now, these are her own 4, and they may be fine, but it's a little disturbing when a physician on his or her own will make up the rules for themselves, and we have to be able to maintain this kind of ongoing open conversation here if we're going to manage this appropriately. So the courts have put us in a really difficult position here because they say this is legal now, you have to provide the service, but we're scrambling, as you've heard, on many levels to try to put some parameters around it and ensure that we're going to do it appropriately, legally, and ethically as we move forward. So my final slide here. This is a quotation from a ethicist in the United States that was written in 1989, so almost 30 years ago. And she says, "It is easy to declare with great fanfare that we will brook no diminution in our commitment to supporting and caring for those at the edge, even if euthanasia is allowed." Of course, that was part of a discussion before the Oregon law came into effect. She said, "But physicians are fallible, hospitals are bureaucracies, and stress is real. There is ample cause to fear that providing an exit marked euthanasia would make all families, clinicians, and researchers less prone to linger in the room of the dying." And I think from an ethics perspective, that's one of the things that we're concerned about. People at the end of their life are at the most vulnerable point in their life oftentimes. They're clearly at the stage, if somebody's asking that their life be brought to an end, this is an irreversible decision. And in some cases, it could only be hours. Some cases, it could be days. But given, when we're not quite sure yet how the law is going to allow, it could be weeks, months, or maybe even years. And we have to be careful that we don't say, well, because they've got that right, then we have to allow that for them. The terms sympathy and compassion, both of them mean to suffer with. Sympathy means to suffer with somebody. Compassion means to suffer with. We don't want to leave people to suffer on their own and say, well, they can't handle their suffering anymore, therefore we should end it for them. I mean, that's what we do to our dogs, for sure, but they're dogs. You know, it's not a clear analogy to say, well, you know, we wouldn't allow an animal to suffer like that. Well, you can't really suffer with your dog in the same way as you can suffer with a loved one, to come along beside them and try to support them. Again, I'm recognizing that there's only so much you can do in that area. There will be exceptional cases where we say that we need to assist this person to end their suffering. But I think we want to be careful not to sort of say, well, now the door is opened here, and so we can forget about all the rest of that kind of stuff and full speed ahead here. We have to be careful that the exit door that says euthanasia isn't the one that says we don't have to linger by the bed of the dying person anymore because this is a done deal. So that's some of my ethical concerns. And as I said, they're reflections of an ethicist. They're not everybody's ethical perspective.
And thank you so much, Daryl, for raising some of those ethical considerations and reflections. So we're going to turn things over now to Pam to facilitate our case scenario and frequently asked question section. And again, just want to say a huge thank you to our panelists for those opening remarks. A lot of great information, a lot of information for us to reflect and think about. So thank you.
Good afternoon, everyone, and welcome to the session today. So I'm going to move us right along and keep us on time, certainly so that we can complete the session in a timely manner as well. So we'll begin with the case study, and then I'll ask each panelist to comment on the case study. We'll give them around 5 minutes each, and then we'll move to the frequently asked questions. Here's our case scenario for today. Mr. K, age 50, has suffered with ALS for 8 years. He is now rapidly deteriorating and wishes to further explore MAID. As a healthcare provider, you have already decided that you do not wish to take part in MAID. Also, his wife and daughter have already told you they do not want Mr. K to even explore the possibility of MAID and have asked that you not discuss the topic at all with Mr. K. So to begin discussion on the case study, I'm going to ask Judy to comment, and I'll ask the presenters actually to stay seated. Okay.
Thanks, Pam. Certainly an interesting case and one that we can imagine would be a reality for us to face. I guess comments that I would have from an operational basis or perspective would be, as a professional, if you feel that this is not something that you want to be involved with, it's very important to reach out to your supervisor, to your managers about those feelings. So there can be some consideration of how the patient will be supported and that your rights will also be respected. Also a comment, of course, that we're seeing in various professional regulations, we don't just walk away. We do still have to provide for the patient. And if that means in a conversation saying, I don't know a lot about this information, I'm going to find someone who can answer your questions for you, just somewhere to keep the conversation alive while you seek the appropriate information. And as we said, we're all still working to get the answers for the patients in a timely way. And so we want to help support you so that in turn we can help support patients in this. I think other than this, a last comment about the family, very challenging situation. Of course, we have to recognize who our patients are and who we are serving and respect the rights of the individual and the rights that they want, understanding that we're not telling them what to do. We're providing information so that they can make informed decisions, in this case about MAID, about all the processes, why they're asking for this information at this time, what their circumstances are that is making them think this way, and what they want, but not shying away from supporting the patient where they are in that moment, so that they have that fulsome discussion and can make the right decision.
Excellent. Thank you, Judy. I'll ask Daryl, followed by Trudy, and then Michael to respond.
Right. Just following on from what Judy just said, clearly, from your perspective, if you're not comfortable with actually participating in medical aid in dying, you can, you've got the right to be a conscientious objector. But even at that, it is now a legal option for someone to explore this. And so as a healthcare provider, you've got to be able to provide the kind of support that you can, both to this individual and to his family. And I suppose one of the things that we're concerned about ethically is that we don't want to make a division between a family and their loved one. We want to try to administer, provide care to the whole family. So from this perspective, we'd want to explore with the family exactly what are your concerns. Clearly, if your husband and father is at this point, he's been suffering with this for 8 years, he's been fighting hard, and ALS, that was the condition that Sue Rodriguez suffered from. And her concern was that when she reached a point when she was unable to take her own life, all of us who are able-bodied, under the law, we've got the right to take our own life whenever we want. That's the law allows us to. But Sue Rodriguez, her Supreme Court challenge was based on the fact that she could foresee a time, given that she had ALS, that her life would become unbearable, that she would want to end her own life, but she wouldn't be physically capable to do that because of the physical condition that she was in. And so she was petitioning the court then, if she couldn't take her own life, she said that her equality rights under the law were being violated because anybody else could take their own life if they found their suffering unbearable, if they were capable of doing it, but she wouldn't be able to. And that was where she was petitioning the court. So here we've got a gentleman who's suffered for 8 years. He's got a deteriorating condition. If he's reached this point, clearly his suffering must be unbearable for him. I expect that the suffering would be unbearable for the family to think about losing their loved one at that point as well. And although I am ethically opposed to medical aid in dying, it is the law. And I think we have to be able to provide the kind of support we can to a family and to explore with them where do we go from here. It's not that he just was diagnosed last week and he said, I've got ALS, shoot me. He's saying, I've fought the good fight and I've reached the point where my life is unbearable. We'd have to have those conversations with the family and hopefully get them on board with us in moving forward. So.
Okay. The criminal code, as we've touched on already, provides that nothing compels an individual to provide or assist in providing medical assistance in dying, and that's the conscientious objection piece. So that's the criminal code, but all of you sitting in this room are bound by another code as well. And that's called your code of ethics and your professional standards. So anytime you're in a situation where issues of this nature come to the forefront, not only do you have to look to your criminal code, you also have to look to your standards of practice and your code of ethics, because those are your guiding principles for you as a professional. You're a self-regulated body, member of a self-regulated body. We have 3 banners up there for self-regulated professions that the government of this province has said you have the privilege to regulate your profession. And in regulating your profession carries a responsibility to the people and the population that you serve. And that's where your professional standards come in. That's where your code of ethics comes into play. All 3 banners that you see up there, all of those organizations have already developed some guiding documents to assist members in walking you through what's appropriate to do in the circumstances. And I think that is a good starting point to look to see what your regulating body provides to you to assist you here. And as well, not only your regulating body, the code, but your employer as well in terms of employer policies. I will say to you that in terms of, because I work with the Nursing Association, the document that is on our website specifically addresses the issue of a conscientious objection and provides some very good direction from my perspective, because I helped write it. but it provides some, I can't take full count, the ladies over here as well. But it does certainly provide you with some direction as to what is expected of you when faced with a situation where your own personal beliefs and values come into play when dealing with a client. And in fact, for nurses, the Code of Ethics specifically talks and provides direction to you as to how you would respond when you are faced with a challenge such as this one, where your personal beliefs are not on all fours with what your client is asking of you. And I'm just going to read, and I've got to get out my granny glasses for this. And this comes from the Code of Ethics for nurses. If nursing care is requested that is in conflict with the nurse's moral beliefs and values, but in keeping with professional practice, the nurse provides safe, compassionate, competent, and ethical care until alternate care arrangements are in place to meet the needs or desires. If nurses can anticipate a conflict with their conscience, they have an obligation to notify their employers, or if the nurse is self-employed, persons receiving care in advance so that alternate care arrangements can be made. So, I mean, very clear direction that you have to act. You have to do something. There is no obligation on you to actually be involved in providing that care, but you can't leave your patient. Something has to be put in place there to ensure that their needs and concerns are addressed. In doing that, I will also point out to you that because we're dealing with conscientious objection here, the other thing that you need to be very cognizant of is that it is important that you not convey your own personal beliefs and values on the family and on the patient. They're struggling enough with this issue as it is. And they certainly don't need to be put in a place where some judgment may be impressed upon them as to what their decisions and options in life may be. So again, there's documents out there, there's great resources on the websites for the self-regulating bodies that are certainly a guide to starting that conversation. And I know from the Nursing Association's perspective, they take practice calls every day on very difficult ethical types of issues and are a tremendous resource to avail of. So that would summarize my comments in relation to this scenario.
So last to me, and I won't say much, as a policy person, we stay out of clinical situations. That's not my area of expertise. I would notice, though, that we've talked primarily in talking about this case, about the issue raised in the sentence there about how, as healthcare practitioner, you've decided that you don't want to take part in MAID, but we haven't really focused on the issue addressed in the last sentence of the case study, which is that the family has told you that they don't want you to talk to the patient about that, no matter what he wants to talk about, if I could paraphrase. So I'm not the one to answer that question, so I'd turn to other people at the table here and maybe others in the room for their thoughts on that question. When we were talking earlier, we said that the family, the choice for MAID must be a free one made by the patient, and the concern there was that there cannot be any suggestion that the patient was coerced or persuaded into this course of action by their family or anyone else for that matter. It must be a free choice, but we didn't discuss the other situation where the family was trying to or was suggesting that a course of action not be followed or not be even explored. So maybe I'll just put that back on the others at this table to say what you think. I mean, my sense is that this would be a very difficult situation for a nurse or any other health practitioner to be faced with, particularly if they feared reprisal from a family in the case that the patient did choose to elect medical assistance in dying. So I don't know who would want to jump on that, but I'll throw it out there.
I'll just offer a comment, Michael. I mean, we and you as healthcare providers that work in the field, we face those kinds of things all the time. You know, don't talk to, don't tell mom she's going to die, or don't, I mean, and you can understand why people are sensitive about those things, but at the end of the day, it is their health care, and you have to manage that with the family very directly. Because again, it's not unlike other things that we've had to deal with in terms of the actual kind of request that Dad doesn't know he's going to die. Usually, Dad knows he's going to die, but. Been involved in cases where family members said, "Don't talk to Dad about that he's going to die," and Dad says, "Don't tell my family that I'm going to die." So yes, it's. I mean, being clearly, it's end of life. It's this. This is a very difficult situation, and people's emotions are going to be running high, and they're often running high for healthcare providers that have to work in that context as well. But as Trudy said, we have to be careful not to wear our own perspective on our sleeves and try to be sensitive to all of the people involved.
So thank you to the panelists for some very interesting, certainly some great learnings for all of us. We're going to move right along now to some frequently asked questions that we get asked, certainly, as practice consultants. So I'll start with frequently asked question number 1. I can't believe that just worked. Mrs. L, age 80, has been living with terminal cancer for the past 2 years. During a recent visit with a healthcare professional, Mrs. L, she talks to you. During a recent visit with being the healthcare professional, Mrs. L, she talks to you about it, wanting it to be over. Should the healthcare professional inform her about MAID? I'm going to ask Trudy to take the lead on this question, and then if any of the other panelists want to respond, that would be great.
Okay, so you remember back when I did my presentation and I told you I was going to talk a little bit more about this concept of what it means to counsel. And that is a very live issue with the amendments to the criminal code. And the reason it's a live issue is because under the criminal code, the word to counsel has certain meaning. And for all of you sitting here, nurses, social workers, licensed practical nurses, you're involved every day in therapeutic counseling relationships. There is a big distinction between what it means to counsel someone in the criminal code and what it means to counsel someone in a therapeutic relationship. Under the criminal code, to counsel means to, and it's specifically set out for the purposes of the act, being the code, counsel includes procure, solicit, or incite. So it's important that when somebody is looking to you for information, that you're not falling into that category of procuring, soliciting, or inciting someone to participate and engage in MAID. And it is important to recognize that distinction. In this particular case, we have Mrs. L wanting it to be over with. Well, the first thing that you need to ask yourself, or ask Mrs. L, is really, what does she mean by that? What does that mean? Because a lot of individuals who are enduring very difficult medical conditions, their experience and the suffering that they're going through, they may quite frankly say, I want this over with. But does that mean they're asking you for information on medical assistance in dying? That's a big leap. If you make that assumption and automatically start providing information, then you're on that slippery slope of whether or not you are in fact inciting someone to engage and participate in MAID. So again, the document that we have on the Nursing Association of Newfoundland and Labrador's website addresses an issue of how to protect yourself in that type of situation. And one of the pieces of information that we have in that document is to make it very clear is that if you are in this type of situation, unless somebody explicitly asks you for information on MAID, you don't provide it. It has to be an explicit request, because you don't want to be in a circumstance where you're being challenged by some other family member who didn't want you giving this information and suggesting that you are in fact encouraging and inciting participation in MAID. This particular case raises a number of other challenges as well. What does it mean that Ms. L is terminal? Does that mean she falls within the definition of what is set out in the criminal code to meet the eligibility criteria? Is Ms. L competent? Does she have the ability to make informed decisions about her care? So those are all live questions and issues that arise in the context of this type of scenario. The other thing I'm going to point out to you, and we've talked, and Daryl spent some time talking about, MAID should not be the first thing we go to. You need to be assessing where the individual is, what we can do to facilitate care for the individual, and what are the palliative care options. And that's important because the criminal code, the amendments to the criminal code specifically, if I can find them here, addresses that issue. Under the eligibility criteria, one of the eligibility criteria under the code is that there must be informed consent. And informed consent means that the individual must have received information in relation to palliative care and what their palliative care options were. So simply, if somebody says, I want information on MAID, then part of the giving that information and part of the eligibility criteria is for the individual to also have the information on the other options and resources and services that are available to address the issues and concerns that they have. So I think that probably concludes what I have to say in relation to that scenario.
Would any other panelists like to comment? Good? Okay.
I'll just add as well that as we review cases for MAID, the actual eligibility requirements are actually deemed by physicians. That it is a very much, it can be a very much team-based process. So the input of all healthcare professionals to the physician is important, but it's actually the physician who is doing the deliberation of candidacy and capacity and deeming a person is eligible or not. So remembering, even in our role as we speak to patients, provide information, the ultimate assessment of the patient is left by the legislation in the hands of the physician, two physicians.
Yeah, the colleges, the different colleges around the country have not sought to put further definition around the parameters. So they haven't sought to further narrow down what reasonably close to death means. So that's, it's, yeah, to
The
determination by the
legislation
physician.
allows nurse practitioners as well, does it not?
That's
Yeah.
true.
So,
Thank you,
yeah,
yes.
yeah.
But
Appreciate
in
that.
this province right now, that it's not within the scope of practice for nurse practitioners.
Right.
That is something that is under review and the association is working on.
But no, it's true. Thank you, Daryl. I did quote legislation, and you're right,
Right.
it is nurse practitioners as well.
Okay, Okay, thank you. I'll go to another frequently asked question. Mrs. M, age 30, has been diagnosed with a brain tumor, but is in the early stage of the disease. She's married with 2 children. She asks her healthcare professional about MAID. How should the healthcare professional respond if they are not in favor of MAID? So what would be some of the legal, ethical, and practice considerations? And I'm going to ask Daryl to take lead on this question.
Right. Well, I suppose ethically, your first question would want, if this is a young woman who's just been diagnosed with a brain tumor, you'd probably want to make sure you knew what the nature of that tumor was. That it sounds like it's very early in the conversation. And again, going to Trudy's last point, and something I tried to emphasize before, the first thing we don't want to the first conversation we don't want to have with anyone, whether they're terminal or not, is whether or not, how might we most effectively provide medical assistance in dying for them. This sounds like she's just been diagnosed. She's a young woman. She may have many years ahead of her yet. She may have an operable brain tumor. It may be, she may not be terminal. Those are the kinds of questions we want to start to have. Again, you know, the idea of being a conscientious objector is in there if you are personally opposed to it. But I think, you know, the fact that this young woman who's got 2 young children, she's obviously got a lot on her mind, and she's lots of concerns and so forth. We don't have very much information here, and you may not have very much information about the person either the first time that you come in contact with them. I think this is a conversation that you want to delay at this point about MAID, and perhaps raise, well, what other kinds of options do we have here? Clearly that's on the table, but we may not be at the point where we want to have that conversation or need to have that conversation yet. So I think that's where I'd start off anyway.
Any other comments?
The only other comment I'd make would, because it asks if you're not in favor of MAID, is the second part of that question. And again, I would just reiterate what I said earlier in terms of looking to your professional standards and looking to your code to ensure that you are compliant with not only the criminal code, but your code of ethics and your professional standards.
Okay, our last frequently asked question. Jane, a healthcare professional, recently returned from maternity leave. Prior to her leave, MAID was not in law. A client recently asked her about MAID. So what does Jane need to consider, and how should professionals prepare for questions pertaining to medical assistance in dying? And I'm going to ask Judy to take lead on this question.
I think when we receive these questions, and I'll say in a way that we weren't expecting them, I think it's almost, we're almost saying the same thing. I mean, we have to still respond as professionals within our scope, and then we have to seek the information that we need, recognizing that we have to support the patient, but also make sure we give accurate information. Asking about MAID and what it means, I mean, that's almost, it's so broad. You know, what is it? Can I get it? What would I qualify for? Those things you might not even know. And they may not, you know, relevant to the case. Where does this fit in? Is it just a conversation? Is it about me? Is it about general? There's so much context. So you have to sort of understand where the patient's question is coming from, explore that, and understand what you're able to provide. Within our organizations, we're all learning. I'm in a senior management position, still learning on this panel here today. But certainly as professionals in the front line, we do have people who can support us with that information. Ethicists within our facilities, and other managers who've taken a role in seeking out those people to help provide the information to support you, support your clients, is certainly key.
I mean, we still are in very early days, and so there's, I expect that many of you may face these kinds of questions. And it may not be because somebody necessarily is thinking about it for themselves. They may have a loved one who is very ill, and they're thinking about that might be something their loved one might want to explore at some point and so forth. Hopefully, as we move forward, as the province gets rolls out where we are with this, as Eastern Health continues to develop its policies and procedures, we'll be able to we'll have some literature available so that everyone of you doesn't have to sort of feel like, well, I have to become some kind of an expert on all aspects of MAID right now, and be careful that I don't misdirect somebody here, that we can point people to a website and to other places where they can get the kind of information that we want. Because one thing we need to have is a clear and consistent message around this. It is the law now. It's allowed under the law, irrespective of what your personal position is. And so now we, as healthcare providers and as organizations, as a province, have to ensure that we're providing a clear and consistent message about what that means and how you can access it and under what conditions. But again, those are things that are in the process right now, and hopefully we'll have some of that sorted sooner rather than later.
When I was in my 4th year social work, I had the good fortune to interview Joseph Smallwood on resettlement. And during the course of that interview, he said to me, education, Ms. Button, that's education with a capital E. That is important. And that is, as practitioners, you need to educate yourself. The world is changing, and the laws are evolving and changing to keep up with societal values. And it is important that, as professionals, you keep abreast of those changes. And to do that, you need to, for example, in this particular case, you need to know what the criminal code says. You need to take it and read it. You need to read what your regulatory bodies say in relation to this issue. You need to take a look at what the regulatory bodies say for the people that are working beside you. What are their regulatory bodies saying in this circumstance? You need to as well look to your professional insurer to see whether or not your professional insurer, your liability insurer, is providing you some direction and guidance in this particular area. And of course, you also need to be cognizant and be aware of your employer's policies to ensure that you're in compliance with your employer's policies. And at the very least, if you have concerns and questions at the end of the day, you should consult with a lawyer to ensure that you are not in breach of the criminal code and that you are going into this role knowing exactly what your duties and obligations are under the law and under your professional, your duties under your professional organization.
Thank you to our panelists. We'll move along now to a question period. It's going to be limited to 5 minutes, so we'll probably get 2 questions answered. If you have a question, we're going to start in-house, and then we'll open the opportunity to anybody online. And of course, questions that aren't answered here today, please feel free to connect with individuals, maybe your employer, maybe us in the regulatory body, to address those questions that we're unable to answer today due to timing. Anybody in-house have a question? Or have we just answered every question you have? Okay, I see a question right here. I'm just going to wait, and if you could speak into the microphone, that'd be great. Thank you.
I think it was the first case that you showed, maybe the second. It was about an 8-year progression of ALS that was rapidly deteriorating, and how to address that when someone asks for information on MAID. And I'm not sure if it can be answered today, but how reasonable is it, if you don't have the information and you're not for MAID, to consider it in a rapidly declining situation, even though it's been chronic, to meet all the needs of the criminal code and consent and everything that, you know, and if the person's in acute care in hospital, I guess, for frontline staff.
I'll take a stab at it. As while the case isn't a real case, it is far from cases that we've actually communicated with patients about, people who've requested information about MAID. And I won't joke with you, it's been a struggle at times to pull the necessary supports together to meet a patient's need. We are getting better. We, as people, to follow what Trudy said, as practitioners are becoming educated, they are also growing in confidence to participate in MAID in an effort to support the patient. And that may not be fulfilling a MAID request, but to be able to respond to questions and so forth. So I think I understand what you're saying. I think your question is, how ready are we? And I can only speak about the immediate context of Eastern Health and even urban Eastern Health. We're getting more able to be responsive to that, and we're building capacity regularly. Even through discussions like this, we hope to build our capacity. It's not there yet, but we're getting there.
Siobhan, do you have a question online?
So the question online is, as a registered nurse who is aiding in MAID, is it necessary to review or examine documents to ensure that the criteria has been met to satisfy the safeguards? And does this documentation belong on the health record?
I can speak to that question and direct you to, in fact, the Canadian Nurses Protective Society has a fabulous site that deals specifically with medical assistance in dying, and that is the insurer for registered nurses, and they specifically address that issue. I'll just read what they have on their website. Before participating in the process, RN should verify that a medical or nurse practitioner has documented their determination that the conditions set out in Section 42(1.2) of the Criminal Code have been met. For the most part, this can occur by 1, reviewing the chart to determine whether documentation clearly indicates all requirements have been met, or inquiring directly with the physician or the nurse practitioner providing MAID. The article goes on to suggest it would also be prudent for the nurse to carefully document in the client's chart what steps the nurse took to verify the determination that eligibility criteria and safeguards have been met. So there are resources out there. So some of your questions, if you look and read, you'll find that there is probably a lot more information out there that guides and assists you in working through these types of issues and information.
Okay, so unfortunately our time for questions is up because we have to go on to concluding remarks. However, I do encourage you to come down if you're in-house to ask some questions afterwards, or certainly connect with us or one of us as a practice consultant in the regulatory body or in your employer, for example, professional practice, if you have any more specific questions. So we'll start now with concluding remarks, and I'll ask Daryl to start, followed by Michael, then Trudy and Judy.
Well, I'll just reiterate a couple of points I've raised already. I mean, medical aid in dying is now the law of the land. That's the reality that we live and work in. As I said, the ethical issues are still there, and what all of us have to be aware of is, irrespective of our personal perspective on medical aid in dying, we have to approach the issue very carefully and sensitively. We're in a kind of a nebulous time right now as we're trying to work out the details on how to proceed. So I'd encourage you not to be too enthusiastic in running forward if you're all for medical aid in dying, or to drag your feet too much if you're against it. because the fact of the matter is we have to be able to serve our clients ethically and sensitively and appropriately. And this is the new reality. This is the part of our healthcare practice now. And so we have to work together to ensure that we're going to do it right.
I'll ask Michael to go next. Thank you.
Thanks. So I just want to conclude by saying that as health professionals, I think it's important that you reflect on the fact that even though you have your conscience rights, those rights are not absolute. You do have the responsibility of duty of ongoing care to your patients. You can't, just to reinforce what some others have said earlier on in relation to one of the cases, you can't. But to be even more blunt, we have seen situations already in this province where health professionals have been asked about MAID, and they said, "Well, I don't know anything about that, so that's it. You can't do that." So, why don't you call the Health Science Center? I mean, you can't do that. So you do owe responsibility to your patients and your profession to educate yourself and to provide ongoing care and information to the patients that you interact with, just as healthcare professionals in our system. As Darryl suggests, we're going through a transition. We've had. I think 6 months ago we were worried about how we would get through this transition, but we've already had brave and patient-centric healthcare professionals who've stepped up and responded to their patients' wishes that I don't think those healthcare professionals fully understood, and they took actions at some cost to themselves. I think that's a situation that you often are put in, so I have a great deal of faith that the health professionals in this province will rise to the challenge and will move into the new normal that I would hope looks a whole lot like the old normal, except with a better approach to end-of-life care.
The theory of my case, as you've heard, is education. So I'm just going to conclude with that. But I think as part of the education, you need to be aware, from what we've discussed here today, as a professional, there's two very distinct aspects to what you do as professionals. One now is caught by the Criminal Code of Canada, so you need to ensure compliance with the Criminal Code of Canada, but as well as a professional a member of a professional body and a professional organization, you also need to ensure that there is compliance with your professional organization in carrying out the duties that have been thrust upon you as we move forward.
I think there's a theme here for these final comments, but thank you for your interest in MAID. I'm just going to share a little observation that I've been privy to in terms of how physicians have been approaching this for Eastern Health, in that there is certainly a lot of anxiety about this for physicians, but also a greater understanding and a shift in thinking based on the education that they've received. So recognizing that a physician involvement doesn't have to be all or nothing, that there are elements of support for MAID that don't necessarily mean writing a prescription or delivering a lethal injection, that physicians have shown that they can, with appropriate education and direction, can move their thoughts. in regard to MAID. And that's not me being a champion for this. That's just me recognizing that as healthcare professionals, we do need education in order to make decisions for ourselves regarding our involvement. So with the theme of education and recognizing this is an evolving and changing landscape for us all, you know, it's my recommendation at the end, my concluding comments would be continue to educate yourself, continue to reflect on what this means for you in your clinical practice, and be prepared for how you're going to respond, and whether that's a personal response or a secondary response in terms of operationalizing your services in the area that you work, while keeping in mind the patient first. These are actions we can do now to better prepare ourselves and to better improve our confidence.
Okay, so we will conclude now. So I'd like to thank certainly our panelists. It was great discussion here today. And I'd also like to certainly thank the Centre for Innovation in Teaching and Learning, especially Lorna Yard, our producer, who's behind the scenes today. Thank you for coming and participating. Good numbers here today, and I know online we have over a couple of hundred people joining us across the province as well. So that's great. Thank you for coming, and thank you for joining online. Again, if you have any questions, additional questions, please feel free to come down and ask us. We do have some resources here available today as well. We have the document that Trudy has referred to about registered nurses and nurse practitioners aiding and medical assistance in dying. We have the document from the College of Licensed Practical Nurses of Newfoundland and Labrador, their practice guideline on medical assistance in dying. And we also have the Newfoundland Labrador Association of Social Workers document, medical assistance in dying and what social workers need to know. So I encourage you to visit our regulatory bodies and the websites for additional resources and to connect certainly with professional practice in your organizations. I will ask you to assist with planning for next year, that you do complete the evaluation forms that are available in-house right here. We have some up in front and some in the back of the room. And also, you can go online to the Newfoundland Labrador Association of Social Workers site to complete an online evaluation. For registered nurses who wish to use this for continuing competency, I hope for those online that you did register, and I also have some forms here today that we can certainly sign for you. And social workers attending this session also may claim 2 CPE credits under the workshop category for their continuing education as well. And I know for the College of Licensed Practical Nurses as well, certainly this can be used. I'm looking at Wanda now to nod her head as for some continuous learning hours. Starting April 1st, their program starts. So that's great. So thank you for your participation, and thanks again to our panelists. And everybody have a great day.